All right, everybody, welcome to the Gyno Gurus podcast. It's been a few weeks since we filmed, so it's good to be back. So today we actually have a special episode. We're kind of taking a little detour from what our initial plan was in terms of content. But today we're actually going to be talking about the FDA removing the black box warning on hormone replacement therapy. It's been a very popular topic of conversation the past few days since the press releases came out. So we were going to just kind of briefly talk about, number one, what that means, what a black box warning is, and then I was actually going to have Dr. Mandel kind of walk us through just his experience with hormone replacement therapy in general, just because you've been practicing since 1985?
87.
87. So he's walked through many different seasons of hormone replacement therapy, and we are just kind of coming out of a time frame where it was like a scary thing the last couple decades, and now the fear of it is kind of diminished with this black box warning being removed. So I'm just going to kind of let you get into it and tell us a little bit about what you've seen over your lifespan in medicine regarding hormone replacement therapy.
So when I started out in medicine, the recommendations were actually that every woman should be on estrogen after menopause. I mean, it was almost universal, and it was just the norm. And then the Women's Health Initiative study came out in 2002, I think, and it dramatically changed the whole landscape. Suddenly, estrogen was looked at as dangerous, and the public really backed off on the desire to be on hormone replacement therapy. So let's go through what happened. So the FDA has petitioned the pharmaceutical companies to change the package insert on estrogen. And the FDA, for a lot of medications, have what they are called black box warnings. And black box warnings are sort of like telling clinicians you have to be very careful about using this product in a patient. And so, for example, the black box warnings for estrogen were breast cancer, cardiovascular disease, breast cancer, dementia, and abnormal bleeding were the... Did I leave something out here?
I think it was cardiovascular disease as well. Yeah, so
Yeah,
it was cardiovascular disease, breast cancer, dementia, and then the endometrial cancer risk for unopposed estrogen. Yeah.
Right. And
which still remains.
Right. So the black box warning, like Alex said, for undiagnosed bleeding, vaginal bleeding, is still there because estrogen definitely increases the risk of uterine cancer if you use it without balancing it with a progesterone or a progestin. And the difference is progestin's a synthetic, progesterone's natural. And that has a big impact on a number of things, including risk. So natural progesterone is thought not to increase the risk of breast cancer, whereas synthetic progestins are thought to increase the risk of breast cancer. Natural progesterone is thought to probably not increase the risk of blood clots forming in your calf that could then break off and go to your lungs. That's called venous thromboembolism, whereas synthetic progestins are associated with that. So it's so when you go on estrogen, if you have your uterus, if your uterus is gone, you don't have to worry about uterine cancer. But if you have a uterus, then you have to balance it. So undiagnosed bleeding, which in the list, what we call a differential diagnosis, on that list is uterine cancer or precancerous conditions like hyperplasias. And that would be a time where you probably wouldn't want to give somebody estrogen. No. Otherwise, that's really the only remaining
black box warning
risk. They remove the other risks from the black box, but that doesn't mean the other risks aren't there. It means that they're at a lower level. Now, from a cardiovascular disease point of view, if you start hormone replacement within 10 years of menopause, it seems like it doesn't increase the risk of cardiovascular disease and may even prevent it. Dementia, they've taken that off. I never thought the data on dementia was really that robust. I always questioned that part of the black box warning. Anyway, so let's talk about the benefits of estrogen. Why would you want to go on estrogen?
So I think something that's like important too is like whenever we talk about benefits of estrogen therapy is like recognizing, because I mean basically every tissue in a woman's body is an estrogen dependent tissue. So it's like whenever you go through menopause, because I mean we haven't really talked about menopause a whole lot on the podcast, but honestly this warning being removed from HRT, honestly we were talking about it before we started. I think that we should do like a series over menopause and HRT because it's such a popular thing. And not to get too off topic, but kind of going back to studies like you were talking about, I don't know if anyone has seen the fertility and women's health video that was posted by the Diaries of a CEO on YouTube that has like 2 million views. But one part that really stood out to me in terms of like research and menopause, they were saying how whenever you like in women's health, when you look up fertility and like reproduction, there's 1.5 or 1.6 million studies that pop up on PubMed, and PubMed is where we get basically all of our information from as, providers for, providing evidence-based healthcare. Whenever you look at menopause, there's only 99,000 studies done. And when you look at perimenopause, there's only 8,000 studies done. So just overall, a lot of lack of research and data, which we'll kind of get into a little bit later about like the actual like estrogens and progesterones that we're currently using in HRT versus what was in the Women's Health Initiative, which was something completely different than what we use now. So it's all just very interesting. And they were saying on the lecture that I was just talking about that we spend like $40 billion in funding a year for research, and like less than 1% of it is spent on women's health. And then I don't even want to know what percentage is spent on menopause and HRT.
I totally agree with you. Women's health is totally underfunded.
Yes.
But that's a political issue that maybe will start to change.
Fingers crossed.
And this whatever you think of politics, I don't want to get into that, but you have to commend the FDA for doing this.
Because it will help a lot of women.
Exactly right.
And kind of circling back around to just like talking about benefits and that, women in a woman's body, like all of our tissues are estrogen dependent. So I know we're not going to get too much into menopause, but could you just like describe some just high level symptoms of what we typically see in like a perimenopausal patient, and
certainly
then why they would benefit from estrogen?
What we call vasomotor symptoms, or everybody else calls hot flashes.
Night sweats.
And then you have sleep disturbances, you have brain fog, you have the thinning of the vaginal and vulvar tissues, which cause
very painful sex.
Sex, increases the risk of urinary tract infections. I have some patients who just walking causes discomfort due to severe atrophy of the labia. So those are very significant things that bring women in. And then that would be the most common things. And then there are other things like for health, for example, like bone issues, like right after menopause, there's a rapid loss of bone that goes on for a few years, and going on hormone replacement therapy early on could blunt that effect. So somebody who has maybe a strong family history of osteoporosis or has known low bone density, that would be a good reason to think about hormone replacement therapy. And now there's even data to suggest that estrogen improves insulin resistance. It changes like the fat distribution patterns, like after menopause, women who traditionally are pear-shaped, if you would, now become apple-shaped, and that apple shape is visceral fat. And so there's evidence that maybe estrogen will help improve that. It will help reduce liver production of of glucose, which causes insulin resistance, improves muscle intake of glucose where it gets burned, decreases glucose uptake in fat where it gets stored as fat. So it has profound effects there. And then another common thing, which more and more patients actually in the last few years have come in complaining about, is joint pain after menopause. And estrogen really does make a big difference for those patients. And I even have one patient, and she is about, I just saw her. She is probably mid 80s and has been on hormone replacement therapy. And the reason why is when she started in menopause, she was put on hormones. And when she tried to get off of them, she became fecally incontinent, which is kind of interesting. And she went back on the estrogen and it resolved. So she stayed on it because she certainly doesn't want that to happen again.
Kind of going off of that, because we know that HRT can reduce the risk of colon cancer. Can you elaborate on that a little bit? Because obviously I know that high level, but whenever you were talking about fecal incontinence and getting off of HRT, what's the relation to that?
I think that there are basically different estrogen receptors in tissues. And there's basically two estrogen receptors, which are nuclear receptors. So nuclear, that would be the estrogen receptor alpha and estrogen receptor beta, and they have different effects in different tissues. But basically, the nuclear receptors cause the transcription of DNA and produce proteins that can influence different diseases and such. And as a matter of fact, I'll use, because I think this is better understood with breast cancer, even than colon cancer, but I believe it's the same kind of thing. So estrogen doesn't cause breast cancer. What it does is it promotes breast cancer. And that's a subtle difference, but a lot of women have a very minute breast cancer in their breasts that may never grow into anything. But if you left them alone, those cells would stay there and maybe over the years have minimal proliferation. But if you give them estrogen, those cells suddenly proliferate and you get breast cancer now shows up. So the estrogen didn't cause the breast cancer. It promoted the breast cancer that was there. And so that's a difference.
It's a difference, and it's a big difference.
Oh, absolutely. It's not like ionizing radiation,
right,
where if you radiate tissue, you cause DNA damage, and you can cause cancers. So it's a subtle difference, but it's an important difference to understand the physiology of how these things form.
Sure.
And so it's based on the nuclear receptors.
Of course.
And then, these receptors are in all different tissues. And then you have a protein receptor on the surface of the cells that is thought to have more rapid effects. And that it's thought that might be related to how estrogen stops hot flashes based on the protein receptors, not based on the nuclear receptor. So it's kind of
very interesting.
Yeah.
So I think kind of high level, just wrapping up that part of what we were going to talk about, estrogen has many, many benefits if you are the right patient for it. Just because, again, kind of like we talked about in a woman's body, everything in our body is estrogen dependent. Most of it is estrogen dependent. So whenever you are going through menopause, those levels decline, you suffer symptoms. By replacing that, that's what helps you feel more like yourself.
Yeah.
So I just want to move on also to, because I do want to get into talking about the type of estrogen that was in the Women's Health Initiative, like the estrogens and progestins, and progesterones, because I feel like a lot of people don't know that there's differences in estrogens
totally
and progestins, and basically that there is different safety profiles with these things, and even the route, transdermal versus oral. So I kind of wanted to just talk about that.
So let's go into that. So since you started with the Women's Health Initiative,
Well, first of all,
Yeah.
actually, I think it's helpful to clarify that the Women's Health Initiative is what started the black box warning in 2002.
Okay.
I think we talked about that, but anyways, yeah, basically that the estrogen that was used in the Women's Health Initiative was the equine Premarin
Right.
estrogen, and that's actually not what we use anymore.
Yeah. So the conjugated equine estrogens, or Premarin, I'm just going to use Premarin, it's easier, was the standard estrogen used probably since the 1940s. And that's why they used it in the Women's Health Initiative study, because it was by far the most common estrogen prescribed. And but it is not what we use today. We use we use estradiol. And estradiol is, a lot of people use the term bioidentical. And that's the same estrogen that a woman's ovaries make, okay, estradiol. And they use the term bioidentical just as a little aside. It's really a marketing term because
makes it seem more natural.
Estradiol is not natural, it's synthetic, but it is native. It's probably a better way to put it. Whereas actually conjugated equine estrogens is derived from pregnant horses, hence the name Premarin, and it is natural. Okay, so but it has different estrogens that aren't normally found in people, and so especially after the Women's Health Initiative study and hormone replacement got a bad name, everyone sort of stepped away from Premarin, and so they went to estradiol. But the Premarin, the Women's Health Initiative study, what it had is it had two groups of patients. It had one group of women who still had a uterus, and so those women had to have a progestin to counteract the risk of uterine cancer. And they had a second group that had a hysterectomy and did not need a progestin, and they were the Premarin arm only. So the Premarin group, they actually found a lower risk of breast cancer, okay? But you can't take the Premarin data and say that's the same for estradiol that we use today, because it's not. They're different. So estradiol doesn't reduce the incidence of breast cancer, whereas maybe Premarin alone does. And there's reasons to think that maybe it does. But Premarin is oral, and oral estrogens are associated with a higher risk of venous thromboembolism, and that is a more immediate danger, because if you get that, you could suddenly die from it potentially. So, it's not, Premarin's not all good in that sense. But anyway, the other arm of the study had the Premarin plus a progestin that is less commonly used today, called Provera or medroxyprogesterone acetate, which is synthetic, and that arm of the study had an increased risk of breast cancer and a higher risk of venous thromboembolism. And so there are people who still use synthetic progestins with hormone replacement therapy, but even when I used to prescribe Premarin, I used to still use natural progesterone because of the risk of the medroxyprogesterone acetate, Provera. I always felt the natural progesterone was safer, because there were some smaller studies that suggested that early on in my career that I saw. But so people moved away from using Premarin and Provera, or there was a combination product called Prempro, which contained them both. So they moved away from that. And so estradiol and micronized progesterone sort of became, I'll say, much more commonly used.
Yeah.
Okay. And then there are lots of other products available out there. So it's not exclusively that, but those became sort of in the, I'll say at least the more alternative medicine world, used much more.
Yeah.
So,
Well, and I think also too, like in the Women's Health Initiative study, it was the Premarin plus the Progestin that was increasing your risk of invasive breast cancer, but we don't actually have any data on the progesterone.
yeah.
Or is that what you were
Well,
saying?
progesterone has much less data. It
Yeah.
doesn't seem to increase the risk, and I think it would be safe to say that if there is an increased risk, it's much, much smaller than the synthetic
Sure.
progestins.
But it's just we don't really have any like large scale studies on that,
I
do
don't
we?
believe there are any
Yeah.
large scale
And
studies.
I also think it's worth noting that, like, because we talked about this beforehand too, like progestins versus progesterone, like you won't get some of the same benefits with progestins that you would get with progesterone.
Totally
So
agree.
in terms of like sleep and maybe mood, because you'll be in a better mood if you sleep.
Yep.
But yeah, so progestins don't really carry those same benefits.
Yeah, natural progesterone, the micronized progesterone. I always tell patients, and I'm sure you do too, to take them before at night
Bed, yeah.
because they will make you drowsy for a number of hours. They help you fall asleep better.
Yeah.
So
Which sleep can be a problem whenever you're going through perimenopause and menopause.
absolutely.
So, yeah. So I
Sleep's a
think
problem for me, and that's
you're like, my hormones have been stable my
maybe
whole
I'll
life.
take a little.
Yeah. So yeah. So I think, is there anything else that you wanted to like add to that, or?
No. Well, so the other, so you have the type of hormones.
Yes, and then you have the route of it too.
The route
which,
of it.
yeah.
The
yeah.
route of it's very critical. So if you look at your body, if you take something orally, it goes through your GI system and gets absorbed. And when it gets absorbed, that there's a circulation system in our body called the portal system, where the intestines send everything they absorb to the liver. The liver is the big filter or processor of our body, and estrogens get metabolized in the liver. And so one of the issues is as estrogens are metabolized, they can cause an increase in proteins that cause your blood to clot. So that's why estrogens increase the risk of venous thromboembolism. And so if you take estrogen orally, that effect is much greater. If you take it transdermally, in other words, a patch or a gel or even have a spray, the estrogen doesn't go directly to the liver. It goes throughout your body, and some will get to your liver, so there's probably some increased risk, but it's going to be much, much less. And studies do show this, that it's much less than taking it orally. So the route of administration for it is very important in your risk. On the flip side, the route of administration, when you take estrogen orally, it increases other proteins. One is called sex hormone binding globulin. And in somebody who has like high androgen levels, which could lead to things like acne
And androgen
hair
levels
growth.
is like testosterone.
Yeah, testosterone.
Yeah.
Thank you. It could lower those. So if you had somebody who was complaining of maybe, hair loss, and you evaluate them and you find their testosterone is high, giving them an oral estrogen, you're going to get much greater benefit in that regard than if you gave them a transdermal. So these are the nuances that have to be kind of
thought of for each patient.
Yeah. So treatment should be individualized, and then you might have somebody who you don't want to use systemic hormone treatment, but she's suffering from the thinning of the vaginal and vulvar tissue, and then you can use it just in the vaginal and vulvar area, and that has much lower systemic risk. When you put it on directly on the tissue, obviously the levels are much higher there, so you get a robust effect. And then as that hormone is absorbed and distributed through the body, it's much, much less. So, and the amount you would use would be less than if you were going for hormone replacement. So
and that's why even like some breast cancer patients, like we've talked
some
about
of the
before,
breast cancer,
they're even like able to use some of the vaginal estrogen because the
they're-
amount that you absorb is minute.
right, it's very minute, and
he's a very popular man when he's on call.
Yeah. And so so that's exactly right. And then there are there are other treatments for the thinning of the vaginal tissue. I don't want to lead people to believe that estrogen is the only treatment, but it is maybe the most effective treatment when other things don't work. So, like, for example, if you have dryness with intercourse, you can use lubricants. You can use hyaluronic acid vaginally. There are vaginal moisturizers that can help too, which aren't, there's a difference between a lubricant and a moisturizer. And then there's a vaginal DHEA.
Intrarosa.
Yep, Intrarosa.
Yeah.
The biggest problem with Intrarosa is every time I write it, it's not covered.
Yeah.
And then very few patients get it covered, so nobody wants to spend the money on it, so they invariably say it costs too much and they don't use it, even though I think it's a good product.
Yeah.
And and the interesting thing actually about the DHEA, the Intrarosa, is that there's also testosterone receptors in the vulvar area, and that DHEA is converted to both estrogen and testosterone. So it might even be even better.
That's what people say. It increases their libido. It can help improve that and pleasure with sex and stuff like that, which is great.
Yeah. And I was even talking to a physical therapist who we were having the conversation about testosterone to use on the vulva for pelvic floor issues. So that's
that's cool.
For
another time, for another podcast.
Yeah, we could definitely go off into all different tangents.
Yeah.
But so basically, to kind of sum this up, is the FDA did a wonderful thing by taking away some of the barriers for these for estrogen to be prescribed. It will make a lot of clinicians and patients feel better about getting a prescription for estrogen. But it's not just a cookbook. You want to have your provider have these discussions with you about the risk and benefit, about the route of administration, and things like that. And so it's a good thing.
Yeah. And this will kind of kick off, like I talked about earlier. We're going to, I think after this, get into a series over menopause and HRT and perimenopause. I think that would be a really good thing to do. This will kind of mark the beginning of that journey for us. So I really hope that you guys enjoyed this. I hope you found it informational. We'll kind of go from there. So thank you so much for watching, and we'll see you next week.
Yes. Have a
great week.
great week.
Okay.